You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
We have an aging population taking more medications than ever before. On this podcast, I will interview experts in geriatric medicine to gain insight so we can provide optimal care to patients in their golden years. I'm your host, Dr. Tamara Ruggles, and this is the Geriatric Pharmacy Focus. Well, hello everyone, and welcome back to the Geriatric Pharmacy Focus, formerly called the LTC Pharmacy Podcast. I'm your host, Dr. Tamara Ruggles. And today's conversation is going to be so fun. I cannot wait for it. We have an expert on anticholinergics with us. His name is Dr. Noel Campbell. And if you Google or search any publication on anticholinergics, there is a high probability his name will be on it. He's done so many things for our field. So just a little brief introduction. Dr. Noel Campbell is a geriatric pharmacotherapy expert. He's an associate professor in the Department of Pharmacy Practice at Purdue University and an investigator at the Center for Aging Research at the Regenstrief Institute. Dr. Campbell's research is focused on the measurement and management of adverse cognitive effects of medications in older adults with acute and chronic cognitive impairment. His current initiatives include Alzheimer's disease and related dementias, and he has, as I mentioned before, numerous publications and won several awards. And we just want to let you guys know that since this is only audio, we look so nice. We were talking earlier, just so it's on the record. We look very nice today, even though this is only an audio recording. So Dr. Campbell, welcome. I'm so thankful you agreed to join us. And if you could just tell us a little bit about yourself and how you ended up in doing the research and got excited about anticholinergics.
Great. Well, first, thanks for the invitation, and I really appreciate your work, your podcast, and the opportunity to really spread messages that are particularly important through other formats that are easier to consume than just writing something down or writing a paper and then submitting it and then no one reads it, right? So this is the uptake here is just fantastic. So thank you again for the invitation, and thank you for the work, and I appreciate all those who follow along and acquire information through this way. So yeah, I'll try not to bore anyone, but I think it's fun to talk about how you got here. And I think it's particularly relevant, and I do this periodically with some of our trainees around Indianapolis and as we interact with other trainees nationally and at national meetings, even internationally. I'm like probably many of you in the audience. I was trained as a pharmacist and pursued post-grad clinical training, and I wasn't really quite clear as I finished my pharmacy education, what I wanted to do in life. And I leveraged the opportunities that PGY1 clinical development opportunities offer. In fact, one of the areas I was kind of interested in specializing somewhere, but one of the areas was actually in pediatrics. And I have to thank those in my PGY1, particularly Dr. Maria Whitmore at Ascension St. Vincent in Indianapolis, for helping me understand that wasn't where I was going to spend my career. And that was probably one of the first lessons in my professional career that you learn the hard way by experiencing something and either not enjoying it or failing at it. And I think that's a really important message throughout my career, is that you have to try things and fail at them. And if you do so and you learn from them, then it's never a failure. But I pursued post-grad residency training first here in Indianapolis, and then in doing so, explored some areas of interest and really fell in love with the field of geriatrics, the population that the field serves, as well as the clinicians that support the geriatric population. And so there was such a need and an opportunity that I could sense at being a geriatric pharmacist to support that population. And it was really mutually beneficial is what I anticipated. And so I took the opportunity then to go to the University of North Carolina for a geriatric specialty training. Again, really appreciate Dr. Mary Roth, Dr. Jan Busby-Whitehead, all the pharmacy-friendly geriatricians at UNC as an area where I could kind of hone the skill and expand my area of knowledge in the population of geriatrics. But then, also really appreciate the standards of care at UNC that I learned and realized I got more to learn, right? But after that, I pursued a clinical role and ended up finding a great place to practice clinically here in Indianapolis at then Wishard Health System, now Eskenazi Health System in Indianapolis, and it provides care to low-income and underserved populations of Indianapolis. But it has a fantastic geriatric provider network through IU Health, IU Geriatrics, and Indiana University School of Medicine, and enjoyed that. But I actually learned even then, after clinical training, I felt like I had a lot more to learn as a clinician. And so I was really invested in getting better, learning how to deliver evidence-based care to a field that I think this group knows there isn't a lot of evidence supporting the decisions that we make. And so I started asking questions and trying to understand, well, what's the best evidence-based answer for these types of clinical scenarios, some of them occurring more than others. And through that, I started interacting with some geriatric researchers that were largely physician-based, and started, having more and more discussions and conversations about what they were working on, what questions that I had answers to, and they had similar questions. They said, "This is a challenge. Why don't you come over and work with us and help us answer those questions?" And that was kind of the start of a several-year cycle, and kind of started with an informal training plan, but then a formal training plan to really shift my career a bit away from the clinical space and into a clinical research space. And from that, started working, kind of grinding, kind of writing things that we thought were important, writing why medicines were important, writing why medicine research, pharmacy research was hard, and beginning to understand why it's hard, but it's so important. And then through that, it progressed into the faculty role, found a great home with Purdue University, really supportive of that clinician researcher role. And things took off because I found myself in a great environment and just said yes to opportunities. It was hard at times, it was uncomfortable at times, but then at this point, when you get great opportunities like this to look back on, shoot, look what all I've accomplished. Things that I never thought I would, things I didn't even know that I could. I'm really grateful for that, and happy to share that with anybody else who is interested in more information, and it really helps support somebody else who's like me. I just had a chance to do that yesterday with somebody who's like me, but in a pediatric direction, and is really interested in helping the field, helping the patients in a larger scale, rather than just at an N of one or a one-to-one patient-to-patient series throughout the day, but hopefully helping people in a larger scale. So that's hopefully that was kind of a long-winded answer, but hopefully we didn't put too many people to sleep already.
No, I'm sure you did. We all have our own journey and how we end up places, and I think it's so cool to find out, the master behind this publication. How did he get there, and how did he start doing that? So it's super cool to hear.
And it's relevant, right? So it started with just seeing people and answering the questions that, all right, so this person's using a medicine that's in the Beers criteria. Is it causing a problem? Is it bad? Should they keep taking it? What does the evidence say? What if we stop it? How do we stop it? Mm-hmm. Will they get better? Who knows? The evidence doesn't tell us anything about that. And that, that one question or that one series of questions has been something I've been working on for literally 15 years.
Yeah. And clinicians like me are so grateful because, of course, providers are much more willing to accept our recommendations when there's evidence behind it. And so when we can cite your publication and have evidence behind our recommendations, it really helps. Agreed. So today we were talking about anticholinergics, but it's been decades, since many of us took anatomy or were in pharmacy school. So if you can take us back a little bit and just bring us back to the basics of what does it mean for a medication to be anticholinergic?
Yeah, great place to start. And I'll start with, I'm not really an expert here, but a basic understanding or recollection of why do we call these anticholinergics, and how do we define them for the purposes of our work? Because that was about 18 months of work by itself. But we all know, we can all recognize drugs that we call anticholinergics, but these are medicines that really block the transmission of the cholinergic neurons throughout our body. And as we know, the cholinergic neurons serve a lot of purposes in the autonomic nervous system, the parasympathetic nervous system, the sympathetic nervous system, and even centrally. They're densely populated in certain areas of the brain. So the cholinergic nervous system, or cholinergic neurons that innervate these systems, therefore have projections and have implications for internal organs, smooth muscles, skeletal muscles, as well as in your brain. They can affect attention, level of attention. They can affect alertness. They can affect your ability to find words, use words appropriately, and create memories, store memories, retain memories, pull out memories when you need them. And so it's really the dichotomy of these medications that have activity at cholinergic receptors that, the first round of medicines, or a lot of the older medicines that we talk about being anticholinergics, were created to modify what the nervous system was doing to certain organs, right? And we'll give some examples in a second. But the other part of that challenge, the other part of that dichotomy, is that these medicines that might, for one organ system, benefit a problem that one is having, or a symptom that someone's experiencing, the medicines don't know where they're supposed to work, right? So they do their job at every receptor on which they fit. So they just, you consume them, they're distributed in various proportions throughout the body, and then they do that job throughout the body. And so the concern that we had was, this emerged out of not only the tolerability of these medicines. You take a medicine to reduce the way that your bladder is, the hyperactivity of your bladder, but we recognize that could also affect the way your gut is moving. It could also affect how fast your heart is ticking, but it could also cause some fatigue and sedation, and that could impair first, your level of interactions, your level of awareness, but then over time, it could have other problems. And so that's why we found that to be pretty interesting. And as the field of dementia research, and this is dating back literally to the late 60s, early 1970s, when the cholinergic system was identified as a problem, or a system that was affected in people with Alzheimer's type dementias, that then subsequently created the first treatment that we had for AD, right? The cholinesterase inhibitors were intended to modify the transmission of acetylcholine from one synapse to another and affect how those were working. So despite the fact that the thing that to me is a little jaw-dropping is that despite the fact that we've known the cholinergic neurotransmitter system has had an effect or an impact on the AD diagnosis and the process of neurodegeneration in AD for decades, no one has really ever said, well, what happens if we stop these medicines? Here's a bunch of medicines that we know affect it. And what we found when we started this work in the mid 2000s, around 2006, 7, and 8, when we started defining what are the medicines we need to pay attention to, we looked back at some of the early clinical trials for cholinesterase inhibitors, and they did exclude certain medicines, but their list was so much smaller than what we ended up identifying as about between 40 and 50 medicines, depending on what country you're from. But 40 to 50 medicines that we thought, actually, we can measure, and we know that they have receptor binding affinity, and they cause side effects. And they can negatively impact performance on cognitive tests, which can influence the diagnosis of AD. So whereas clinical trials were, preventing, or they were limiting involvement of cholinesterase inhibitor trials from about 5 to 10 medicines, right? And so that was the first concern, like, why isn't anybody looking into this? And so one of our first projects was to define the list of medicines that we need to pay attention to. And so we defined those that we knew had side effects and had receptor binding affinity of information available. So we felt pretty strongly, and we put those in our highest risk category. But then we also found other medicines that that have some receptor activity, but aren't so much, we don't know how to quantify it very well. And they're not traditionally tied to central adverse effects. So drowsiness, memory impairment, or fatigue that could be not called, they weren't identified as those that could cause dementia, but they were identified as those that had activity at blocking the cholinergic receptors and could theoretically then over time impair performance, but they hadn't really been tested. And so that's what we did. One of the first things that we did was define that list of medicines that we think should be called anticholinergics, and then validate that list and test it against whether these medicines were associated with the diagnosis. So that was one of the early efforts that we did from a research perspective, just to define the list, validate it. And then from that point forward, we start moving ahead into, all right, answering questions like, how well can we draw a relationship between whether these are causal, whether the medicines might be leading to these effects, or even then, how do we change them? And if we change them, do people get better? Is it safe to change them? Or are we introducing harm by changing them? So that's, again, I'm pretty good at these long-winded answers, aren't I?
I love it.
I apologize for that, but I think it's a fun way to learn about, the background for those who want to go back and then think about what was our thought process as we went from the early days into what are we doing now? Yeah.
Right, because in pharmacy school, and I graduated in 2010, so it was probably, as this research was kind of coming out. But I remember learning about anticholinergics, and of course, we learned the mnemonic about anticholinergic side effects, right? You can't see, you can't pee,
Right.
you can't spit, the next one. And
Yes.
then
I actually just learned that last semester when I was giving lectures to Purdue students, and I hadn't heard that one before.
Yes.
But again, reasons that we need to continue to learn, right? Because you never want to miss a good joke.
I know. So, you learn that mnemonic, you learn those side effects. But when I learned about those, I didn't learn about cognitive impairment, cognitive decline, the risk of dementia from these medications. It was just more those other side effects. And so I'm so glad this research is coming out. And also the AGS-Beers criteria, putting anticholinergics on their criteria and bringing more awareness to the risks of anticholinergic medication.
Right. I do think it's important to be aware of those, but I also think it's important, and not to minimize that thought, but I think it's really easy in the way that we explain it, the way that I explain it, it's really easy to draw those connections between the two, that there is the potential causal relationship between the use of these medicines, the mechanism through which they work, and the outcomes that we think it could be tied to. But we still have to prove that, right? And I think it's important to understand that you're using, I think, the right terminology, is that there's a risk of, at least we know that there's evidence to say that there's a risk of poor performance on cognitive tests, on a cognitive battery that could look like dementia. We still need to prove, and we're doing studies now that are trying to prove in a prospective way that there's a causal relationship between anticholinergics and memory disorders or dementia or Alzheimer's disease.
Yeah. And you have done quite a bit of research on it. I know the anticholinergic cognitive burden scale, which came out in 2012. So it's a little bit, it was a while ago, but they list, a couple of your studies as some references, but in that scale from agingbraincare.org, they talk about, each definite anticholinergic may increase the risk of cognitive impairment by 46% over 6 years. Well, I mean, that's a huge number. So,
yep. And that number stems from our first publication, the validation study, where we used that scale. And in full disclosure, it's the scale that we use. It's a scale that we developed, that I developed along with Dr. Milaz Bustani, and we've been using. It's been used in over 1 million people around the world. So it's been reproduced in multiple populations. And that's an important piece, right? There are, as you know, and most people know, there are a number of scales that you can use. And most of them get you to the same place. There are some discrepancies between the scales, and that's okay. That difference of opinion I find valuable. But that's the scale that we typically use and what we're using in our research, because we're using the same ones, at least consistently at our site. And it's important, most publications now, at least epidemiologic studies, are using more than one, like a primary in the study and then a secondary scale to see if results are confirmed, and it's not just a function of a biased scale. So I think that's a really important piece of the literature or the research that we're doing, that other people are doing as well, to make sure that we're using the right tools and easy tools that are easy to use.
Yeah. So this anticholinergic cognitive burden scale, for the listeners, I mean, you can easily access it. It's free to the public. It's a PDF download. I enjoy telling, when I go give lunch and learns at different clinics, I enjoy telling dentists about this, because it's an easy reference for them to see, like, what medications might cause dry mouth, or, so you can think about it for even people other than pharmacists that are in healthcare, that you can show this scale to. But for those of you who haven't seen it, breaks it down into a score of 1, 2, or 3. And the 3s, would be the more definite anticholinergics, or defined as a definite anticholinergic. But one question I had is, so medications like oxybutynin and diphenhydramine have a score of 3, or are one of those definite anticholinergics. But there's medications with a score of 1 or 2, and I'm going to give a few examples. Like a score of 1, furosemide is listed, which you might not think about. Metoprolol is listed. So what I've always wanted to know is, taking 3 medications that have a score of 1, would that be the same risk as taking one medication with a score of 3, or not, since there's not as much research around those medications that aren't those definite anticholinergics with a score of 3?
Yeah, it's a great and common question. So thanks for bringing that up. Before I answer it, though, I do want to include another little anecdote, though, that a lot of times when I talk to people about these in lunch and learns, or in local, regional, state, or national or international presentations, you can open up some eyes and get concerned. You can see concern in people when you tell them about the medicines in the category of 1, right? Because then they're now worried, because they kind of know where you're going to go already with your topic. Like, oh my goodness. And the epidemiologic literature suggests that, as many as 50%, sometimes up to 60 or 70%, depending on the time period that you're looking at. In a year, if you're looking at 1 year of data, a lot of times you'll find a number between 45 and 50% of an older adult population who's currently receiving care, right? So they're medically complex, most likely, but almost 50% are using at least one of these medicines. And as you get into those medicines with a score of 2 or 3, that number declines, but it can still be upwards of 20%. Then when you stretch out the number of years, those numbers can increase a little bit more. And we've done some scans of populations up to 10 years. And we can find that number increases. If you look at anybody who's ever been exposed over a 10-year period, that number can push 50 to 60% using a score of 2 or 3, one of those medicines. So it is relevant. It can be concerning, but these medicines are out there. And as we looked at trends over time in the last few years from our local data and national data sets, the use is pretty consistent, right? So while we love the Beers criteria, just telling people what not to do, telling people what medicines not to use, hasn't really caused a decline in those medicines. Now, there are some arguments out there where there are some ways where people are introducing interventions where you might see some decline. But if you look at nationally representative databases or populations of people, I don't see that as much. So it tells us that there's an opportunity, right, for us as pharmacists. But going back to your question of, there are medicines with a score of 1, 2, and 3. The very crude scoring mechanism for using the ACB scale was to take a person, review their medicines, and apply a score of 0, 1, 2, or 3. And that was their anticholinergic burden, quote unquote, right? In really one of our first publications, we took that approach and we tested that theory because we knew that question would come up. And we tested that and we said among those who were just using those with a score of 1, did those with a score of 1 alone increase the risk of dementia where we had a highly skilled diagnostic assessment, right? So we felt as confident as you can in research in a population that had been through a diagnostic assessment. We feel more confident than using ICD-9 codes at the time, about who actually has dementia. So we had diagnostically evaluated or expert evaluated diagnosis of dementia. So we felt confident about that. And we asked that question, first, do anticholinergics increase the risk at all? The answer is yes. Second, do those with a score of 1, regardless of how many you're using, do those with a score of 1 increase the risk? The answer was no. 2, what if you're using multiple drugs with a score of 1, but you're not using a drug that had a score of 2 or 3? Did that increase the risk? And the answer was no. And we found that what was driving that risk are the medicines with a score of 2 or 3. And so since then, we've really started to hone in on that smaller set of drugs that have a score of 2 or 3. And that's the group that we really want to focus our clinical interventions on going forward. And we also paired that with, like, we're putting on our clinical hat, taking off the research hat, putting on your clinical hat. It would be a really hard conversation to think that you're going to tell a person with heart failure that their furosemide has a potential risk for 5 years, 10 years, 20 years down the road, that it might affect your brain. Well, they'll tell you, I may not be alive in 5 years, 10 years, or 20 years if I don't use this now. So that argument, wearing that clinical hat, makes more sense, and it almost makes our jobs a bit easier. You can continue to use that furosemide. You can continue to use that, appropriately and under advisement or guidance from appropriate prescribers. But we shouldn't be stopping those with a score of medicines just because of their anticholinergic opportunity, their anticholinergic burden. So we feel pretty comfortable, and that's the way we pursued our work more recently, is in the direction of paying attention to those with a score of 2 and 3. And when you look at the scale, you'll see that most of the drugs out there that you see are coming from that category of 3. But we do include those with a 2 as well, because we called those 2s, we gave them 2s because they had a significant amount of receptor binding affinity that was equivalent to the 3s, but they didn't really have as much of a clinical profile for the side effects of cholinergic blockade as the 3s. But that was that could be wrong, but that was just the group of experts that we had working on the scale and developing the scale. The initial scale back in 2006, 2007, 2008 was the first publication. So
Okay.
That's what we made. That's what we decided then. We updated then briefly in 2012, and that's the scale that we're still using. But again, we're focusing our attention on those with a scale of 2 to 3.
Yeah, I think that is so helpful because there's a lot of, medications in that score of 1 where you think, oh boy, they're taking 5 of those. I wonder how bad that is. So that really helps
Absolutely.
clarify, and I appreciate that. I always think, when I'm reviewing med lists, I'm always amazed at the people who are on donepezil and oxybutynin, or donepezil plus Tylenol PM. Can we just for a moment talk about that drug interaction there? And is the anticholinergic completely ridding the patient of the benefits of the donepezil? Or, I know this question wasn't really planned, but I just thought of it because I see it so
It's a great
often.
one. There's no reason to think that it is. And we know that there are people who don't benefit from cholinesterase inhibitors, right? And that's one of the things that I've enjoyed learning a bit more about through the course of my career, is trying to identify people who are benefiting and people who aren't. And we know that there are people who don't benefit from cholinesterase inhibitors, and it's really hard to find people who do, but some might, right? But I have to think that there is and it's been documented at the population level in epidemiologic literature that there are a number of situations that arise from here. And right, it's I believe a money pit. And you can argue that, in part that people got the anticholinergic because of the donepezil is a procholinergic agent, and that really what we're doing is a prescribing cascade of treating a side effect. Or, a side effect is less problematic because they're on that, but it's not an appropriate course of therapy, and nobody would support that. But yeah, it's frustrating to see it happen. And I think sometimes it just takes a recognition that this is a medicine. Now, is it a medicine with an ACB score of 1 that's the most problematic? I don't believe so. But those with a score of 2 or 3 are very appropriate to highlight and, tell people, I'm going to save you some money, and most likely nothing's going to change. The thing that I do that I think is also worth highlighting in the response to that question, though, is when we're thinking about making a change for a drug interaction, as overt as that, it still could be, it's very relevant to think about avoiding withdrawal effects. And they're not that common, but they can happen. And it's really hard to make changes in either of those medicines if you were to abruptly stop a medicine that somebody's brain or body is really used to. And so even, short-term tapers, I say short-term tapers, still 3 to 7 days is a very short-term taper in my opinion, but helping their body adjust with tapering down those changes may help them not overtly react to a withdrawal reaction, because if they'd get a withdrawal reaction, it's really hard to make that change again, or to convince somebody to make that change again. And then you're kind of stuck, right? And then I think you're getting a false feedback that says, like, well, maybe I'm really helping. Maybe these combinations are really helping, because together I didn't feel like I was off of them, when in fact the withdrawal reaction could have explained it. But we're dumping a bunch of money in cholinesterase inhibitors and a little bit of money in most anticholinergics when you see those two interactions.
Yeah. And I think a lot of times when I just send a note to the provider and say, hey, this is cholinergic, this is anticholinergic, they're opposing mechanisms, I think it's just oftentimes they don't see the whole med list, see the interaction, or probably don't have time to sift through it. And so as soon as they recognize it, providers have been very receptive to make a change. But so I was curious about that. Thank you. The next question I have is, when you see a patient on an anticholinergic, one of those 2-3s, are you pretty proactive to make a change? Do you wait until the patient starts having a little bit of side effects, or you see it and you think, let's preserve their cognitive function even though they're doing well on this medication? Let's try to switch it to something different.
Yeah. So this is where our practice becomes the art of pharmacy, right? I developed a pattern or a process through which we can deprescribe medicines in a specialty clinic where people were going to this clinic because they were concerned about their brain health. So they're telling us by their feet, they're voting with their feet that they're already concerned about their brain health. So those conversations were a little bit easier to start, right? Because we would tell them, here's a medicine that we think could adversely affect. It may not be now, but it might be in the future. And there are key elements to that conversation that make it go easier. And some of those are, for a lot of these indications where we're using anticholinergics, there are safer alternatives. So it's easier to tell people, I can offer you a treatment if you think you're benefiting from this one and you want a similar or a different medication to treat the same thing that we think would be safer. A lot of times that conversation goes a lot easier. But there are times when it doesn't. And there are times when we can make a switch right away, or we say, let's talk about it next time if there's too much going on now. But it's good to have a plan of how you're going to follow, how you're going to assess whether that change was helpful or not, and how you're going to have to communicate with the patient, their caregivers, or their providers to make that change. So, but I generally do, as long as somebody, and if we go back to the same conversation about cholinesterase inhibitors, where there are a lot of indications that people are using anticholinergics where some people benefit, some people don't. Some people don't know if they're benefiting. Some people don't know what the anticholinergics is for. Maybe it was for a problem that they had once. It's not a problem now. Or with new information, they realize I'd be willing to taper that down and stop it. And so we wrote our process for deprescribing to include those options and help navigate with the patient what was going to work best for them. And I can tell you, so we're using that process in a randomized clinical trial now, and we're finding that there's a pretty even distribution as we talk to patients in the clinical trial, whether they want to stop immediately, whether they want to titrate down and see if the drug's even working, to know if they even need a new treatment, or they know that they're benefiting. We ask them, how do you know? And then we do a cross taper to another medicine so that they don't go untreated if they know that they're benefiting. And so we have pharmacists that are managing that process, and we keep close ties into those changes. And I think we're going to learn a lot, not only in what the clinical outcomes are as a result of changing these medicines, but also how did the process work, and what types of approaches were people using? Because there's some people who said, I don't even know what it's for. I miss it, 2 or 3 days a week. So, I don't even think I need it. I'm willing to stop it. That's kind of their call, but we tell them, all right, here's what could happen if you find out that here's the symptoms that could come back. And if they do, you got to call us, because we don't want them to get worse acutely, and we can work on a different way to taper it. Or we can introduce another medicine, but sometimes those newer medicines take 4 weeks, 2, 4, or 6 weeks to begin, to really start working in a way that's measurable. And so we have to provide a lot of education for that too.
I would love for that approach to be inside the community pharmacies, where an older adult comes to pick up their amitriptyline, and then that conversation is had. And I hope in the future pharmacy is more clinical like that, and we don't have such demands on us. So we have that time to be able to interact with patients, and we get paid for clinical service, and we can provide that great service right there in the community pharmacy.
Absolutely. I absolutely agree. And in fact, it's been a discussion of a grant to a few different funding agencies like AHRQ or PCORI, where that would be something that would be worth studying. Because I do think that I'm finding the pharmacists that we're working with and doing this still benefit from a little training and exercise in this process, but it's certainly within the realm of within the scope and the capabilities that we as a profession have. And I'm excited to see pharmacists want to take this on, but so it's very doable, but it does take time, and it might take recurring conversations, and it can definitely help and benefit the relationship between patient and pharmacy.
Absolutely. So one last thing here, when you have a patient on a high anticholinergic burden, if they have a high anticholinergic load, how can you, well, first of all, what is anticholinergic toxicity, and how can us pharmacists, help prevent or spot it?
Yeah, so I have a pretty low threshold for what I would define as anticholinergic toxicity. But we talked about it a little bit. We talked about the side effects that you typically talk about, with anticholinergic use. We talked about that previously, but to me, toxicity is just experiencing one of those side effects. Toxicity could be a varying degree of severity, but my threshold is pretty low, right? So I already talked about before somebody recognizes it. This happens quite a bit, and I'm sure it's happened to most of the audience here. But when you start talking to somebody about one of these high-risk medicines or a Beersless medicine or an anticholinergic medicine, and you ask them, do you ever notice that your mouth's dry? Oh, yeah, my mouth's dry all the time. I use these mints, or I always carry a water bottle for that reason. Do you ever notice that you're also on a laxative? To me, I define that as, toxic. Now, we would all understand and agree that toxicity can take much more degrees of severity. But to me, those are the beginning of signs of suffering or adverse outcomes that are occurring as a result of using a medicine that sometimes you're benefiting from, and sometimes you're not. So I have a pretty low threshold for what I define as a toxicity. And my goal is to help, try to balance the risks and benefits of an entire medicine regimen. And I don't want, trying to help people identify and increase their education on any toxicity from any medicine.
Yeah,
but
I think that's
I think
great.
my threshold's pretty low for what I define as a toxicity.
Yeah. And that's another thing, no matter where you work in pharmacy, you can help spot that. If you're a consultant pharmacist and you notice, they started an anticholinergic medicine and the next thing you know, they're on Miralax and Senna-S and some artificial tears. It's an easy way to see that prescribing cascade. Or they walk in the pharmacy and you notice they're on an anticholinergic and you say, is your mouth dry? Have you been constipated? Have that conversation. You can spot it and hopefully decrease their burden, make some changes with their provider to help prevent those more side effects from occurring. Okay, I thought of one last question. I just can't stop. Promise this is the last one. When I look at the anticholinergic cognitive burden scale, olanzapine is listed, right? And I think of my nursing home patients who have dementia with behaviors and they're treated with olanzapine. Can you just elaborate a little bit about that in those antipsychotic medications that are highly anticholinergic that are used to treat behaviors associated with dementia?
Yeah, that's a great question, and it's actually an argument that we had to deliberate on quite a bit, as to how do we handle those, and that actually required weeks of reviewing a wide body of literature to understand who's going to benefit from stopping anticholinergics. And as we took multiple studies and kind of plotted them against the trajectory of cognitive impairment, from the people who were asymptomatic, we know that dementia develops over years, maybe decades. So there's a group who's asymptomatic, but maybe developing the pathology that leads to dementia. There's a group who has cognitive, like early or mild cognitive impairment. There's a group who has dementia, but in a mild form. Then there's a group who has dementia in a severe form, or more so, or moderate to severe stage, where medicines might be necessary to control behaviors. We don't advocate for it. We don't love it. Nobody loves it, but there could be some temporary relief in that group. And as we look at how anticholinergics were studied against cognitive performance on a measurable scale, a validated scale, we found that the use of anticholinergics didn't influence performance on cognitive scales as much in the population with dementia in any stage or form, right? So for the outcome of cognition, improving or worsening cognition, there are inconsistencies in what the literature says about how we should be deprescribing anticholinergics for people with dementia. There are a couple studies that say, they can progress dementia faster. There's some studies that say actually they don't influence performance on cognitive function as measured by a scale significantly in the population. So, that probably tells us that enough of the cholinergic tract is already dead or dying that we're not influencing the ability to perform on those cognitive scales. So we spend most of our attention and focus at the population who's most likely to benefit. And that's the pre-symptomatic or early symptomatic population where we think we have an opportunity to change performance on cognitive measures and hopefully delay or prevent worsening cognitive impairment by turning our attention to, deprescribe in this group, the group who still has enough cholinergic neurologic function left that they can benefit from that. With that said, I understand that there are scenarios that put people at risk, patients at risk, or their family members or caregivers at risk, where a medicine to manage behaviors in those with behaviors can be necessary. And when we have to use those, I think the emphasis or education I try to emphasize is short-term prescriptions, intentional cueing, introducing behavioral economics to try to trigger opportunities to get out of that, change the environment, change the way you're talking to somebody, introduce other interventions or activities that can distract them from those behaviors. Where that fails and you need a medicine, write short-term prescriptions, intentionally follow up or call back to 2 weeks, 3 weeks, 4 weeks later. Did it work? Is the medicine necessary, making those really time-limited trials and trying to stop those as much as possible, because they add cost, they add side effects, and they add a potential risk of death or other cardiac effects or stroke that could be harmful.
Yeah, that was really helpful. I've always wondered that, and I guess I've never heard it the way you said it. And so you're amazing. So I'm just so thankful that you were on today. I have learned so much, and I am certain our listeners will too. And so if people want to connect with you, where can they find you? Are you on LinkedIn?
I try not to hide.
Good.
Maybe I'm at an age where I'm kind of aged out of a lot of social media, but I am on Twitter. I am on LinkedIn, but I'm generally findable through Purdue University websites, and I'm also an adjunct with the Indiana University School of Medicine and an investigator with the Indiana University Center for Aging Research and the Center for Health Innovation and Implementation Science at Indiana University as well. So you can find me on all those sites, and I'm happy to connect. If I don't respond first to an initial attempt to reach out, send it again, nudge me, and I'll respond as much as I can.
Well, it's absolutely would be worth your time, because again, I'm so grateful. You're amazing. And thank you for all you do for our profession, for all your research. I love reading your publications. So I appreciate it. And I hope you have a great weekend.
That's very kind. Thank you so much. And you as well.
Thank you.